Sir, how do these drugs, these methods, these lactulose and other things, affect the absorption of other drugs which he might be taking for other diseases?
He wants to know, can osmotic laxatives be taken by other drugs? Are they not going to impair the digestion of other drugs?
That's a very good question, because most of these people, as you know, are elderly. They are already on life-saving medicines for diabetes and heart disease and other things. Remember, absorption of medication by and large is in the small intestine, stomach and small intestine. The colonic stimulant action or the colonic osmotic action of osmotic laxatives doesn't really hamper the absorption of drugs. The colon essentially absorbs only fluids. It doesn't really absorb salts or nutrients or medicines. Absorption would have already occurred by the time these colonic laxatives work.
Do these have the drug in small intestine also?
Sir, no, they should not be. The small intestinal action of these laxatives is limited. These laxatives are acting essentially on the large intestine, and the only function of the large intestine really is absorption of water and fluids. So it should not interfere.
Right from childhood we are taught about the toilet habits wrongly. जब potty नहीं आई तो strain करना है, और potty नहीं आई तो सारा दिन बेकार है. And some people say that आज potty नहीं आई तो सारा दिन gas घूमती रहती है दिमाग में. So how do you take such patients, referring to the other specialty like psychiatry, or they are obsessed with such things? So how do you handle this?
Once again, a very, very important question. Some people are so obsessed with their bowel movement that their entire day's functioning and their functional output as a working person in an office or elsewhere is totally dependent on how much stool they passed. Most of these people would have passed a stool, but the concept of how much stool they wanted to pass is going to be much more than the actual amount that they passed. This is entirely a disorder that requires explanation. You cannot treat it with drugs. Remember, the amount of stool that will come out is the amount that your colon decides. Should we refer these patients to psychiatrists? My own answer is yes. I don't think any of us, or at least I don't, and many of us don't, have the psychiatric knowledge to decide which medicines to use. Remember, antipsychotics or antipsychiatric drugs are also constipating, and so that's a little bit of a problem. But yes, if someone has such a fixation that they cannot function without an adequate amount of stool, then I would treat it like any other abnormal fixation and request assistance from a professional colleague in psychiatry.
Don't ignore such patients. Counseling, we have been talking about it. They require counseling. Cognitive behavior therapy, it's a role of yoga. There are lots of yoga which helps in constipation. They should be going on to regular exercise, regular yoga, and you will find that many of them will change.
Some people take Kayam Churan. What is that?
In fact, such types of churans, they have caused a lot of harm to the at least the Indians' intestines, and they are mostly their larger content is of stimulant, and that's why, as we have already talked in our talk, that they cause a lot of habit formation, and ultimately a sort of tachyphylaxis occurs, where in later age they becomes inactive, sort of. So they should not be taken.
We haven't covered fecal impaction. How do we define fecal impaction and how do we treat?
Fecal impaction is when we are not passing stools for 24 hours. Again, when the patient was passing, otherwise he was passing stools, and in spite of straining or in spite of giving medication, again he is not passing. For this fecal impaction, again the maneuvers are, first of all, of course, giving the laxatives. If it doesn't work, then is the manual evacuation. If also it doesn't work, then enema, and ultimately sometimes, though it's rarely surgery is required, but sometimes the surgery may be required.
There is a recent article and a lot of work is being coming that phosphate enema should be banned. Practically should not be used in the elderly. And this is give them simple soap water enema.
The reason for that is that the electrolyte changes that occurred with phosphate enemas led to cardiac arrhythmias and deaths in the US. If you're going to use an enema, my suggestion is to use glycerine enemas. They are safe. But remember, when we talk about fecal impaction, the real answer to that is not treatment but prevention. If someone is slowing down stool output and they're in bed and you're suspecting a fecal impaction, please get started on your laxative on a prophylactic basis. Give them lactulose beforehand. Once the stool gets stuck, then you're really in more trouble.
So I have three options when there is a fecal impaction. One is old aged liquid paraffin, that I give them 30 ml of liquid paraffin till it comes out from the bottom. Second is lactulose, 30 ml every 2 hours. And third is polyethylene glycol. And polyethylene glycol you have been using for colonoscopy. And now they say you can give them 2, 3, 4, 6 8 sachets in a day, and over 2 to 3 days, you will be able to relieve chronic constipation. Any comments?
Well, my comment is first, is your diagnosis correct? Has every patient with fecal impaction requires a rectal examination? If the rectum is full of hard, solid stool, then you've got a diagnosis of fecal impaction. If the rectum does not contain it, please get hold of a surgeon or exclude the diagnosis. I would begin initially with a suppository. I would then go on to oral polyethylene glycol and lactulose, whichever is available, probably polyethylene glycol because it works better. If nothing works, then I would go to retrograde methods like using enemas. If nothing works at all, then you've got solid stool still stuck in the rectum, then the original method of using manual breaking up of the stool and taking it out will have to be done. But ideally you should not get to that stage.
Some people say I take enema every day. Is there any harm for that?
I think those things have changed now because our understanding of constipation has improved. So one should definitely be avoid fiddling with the lower area. You could be causing trauma, you could be causing bleeding from hemorrhoids. It's a self-enema which you may be injuring yourself. You could be inducing a fissure. So I think treat the acute condition of fecal impaction by putting a finger, by clearing the rectum, and then prevent it by whatever method has been described so that this situation doesn't occur. Please remember, put a finger in the patient's rectum, and years back K. Das, which is the basics of surgery, had written, in a case of constipation, if you don't put your finger in the rectum, you will put your foot into the clinical situation. You would have missed your diagnosis. So remember this.
I have one study with me which talks about that. It talks about chronic constipation and fecal impaction. And this, as per their protocol, it is 13.8 gram sachets, and that is 8 sachets over 4 to 6 hours period each day for 3 days till the resolution of condition improves.
This is for fecal impaction. No, this makes sense. You have to give big doses. The normal dose for ordinary chronic constipation is about 17 to 34 grams. Is the normal dose of polyethylene glycol.
Which is available in India is 13.8 gram.
So, however, if you're treating fecal impaction, you have to give much larger volumes. And remember, this is not it's not a stimulant laxative. So you need volume production to actually push it down, and at the same time help the passage from below by taking out the really hard pieces, so that at least they can come out. But this is, it sounds like a lot, but this is a safe drug, please remember.
And then what is the advantage of adding electrolytes into polyethylene glycol?
You see, routine, if you're just using a small dose of polyethylene glycol, you're not likely to lose a lot of fluid, so therefore it's fine. If you look at the larger doses of polyethylene glycol, which we use in colonoscopy for the last 30 years, every packet of PEG which is used for colonoscopy preparation has got electrolytes in it, because if you are going to lose 2 liters of stool output, you will also lose a lot of sodium and potassium and other minerals. So you have to add it to the polyethylene glycol.
Sir, constipation in children, is there any change in treatment?
Patients.
Well, constipation in children, which we encounter in our practice, is mainly because of dietary habits and the lack of exercise. Moreover, children, they are sitting in front of TVs, eating a lot and not doing any exercises or play work. So they also develop constipation. If we, so for them, this advisory habits, advisory things like doing exercises, eating a lot of fibers, doing play work, that is most helpful. Of course, we need to rule out some diseases like Hirschsprung disease. After these maneuvers, initially if they fail, then we can add polyethylene glycol for some time, but otherwise we should continue with that. In that also we should emphatically see secondary causes like hypothyroidism or anemia, so all these should be looked for.
Constipation in pregnancy.
Constipation in pregnancy is common and is difficult to manage because we have 2 problems. The number of drugs that we use is limited because we are scared of affecting the fetus. And number 2, you don't want very active diarrhea as evacuation because it might stimulate the uterus. I would begin with number 1, increasing the amount of fluid that the lady takes. Number 2, by adding isabgol, and if that doesn't work, I would go on to lactulose or polyethylene glycol in much smaller quantities than I would otherwise.
My question is that, sir, is polyethylene glycol is safe for all age group, specifically, sir, below the 6 year of age group? And second question, if it is safe, then what is the dose of the polyethylene glycol?
Polyethylene glycol is safe. In children, it is being used. It is safe in young age and it is safe in elderly. There is no denial about it. Polyethylene glycol we have been used over how many years in colonoscopy?
Maybe about 25 years.
So it is 25 years of experience they have been using it for colonoscopy. When it comes to a colonoscopy, you require a large dose. When it comes to fecal impaction, you need 8 sachets. When you need a routine dose, you need a single 1 or 2 sachets. In India, it is available as 13.8 grams. Treatment of IBS with constipation. IBS means pain, discomfort and constipation. What do you do?
Basically, constipation is a symptom of irritable bowel syndrome. So I will say you've got to understand the irritable bowel syndrome, you've got to treat it with different methods. I won't say just give him a laxative, I won't answer it so simply. If constipation is a part of IBS, treat the IBS from the root cause and constipation will take care of itself. I'll not be specific and say choose this laxative, that's not right I think.
Before I end, let me have take-home messages.
First take-home message is that chronic constipation patient should be listened to carefully about his medical history and then start working.
My most important take-home message would be that make very sure before treating your patient of constipation that you are not missing an organic disease.
And my message is please tell your patient it is a long drawn problem. He needs to give time to you and the medicines to act, reassurance and that it is a slow moving treatment.
And my message is very clear. Please don't shift to stimulant laxatives of your own. Try bulk, try osmotic. You have polyethylene glycol, you have lactulose, you have isabgol to try. And if it fails, refer to gastroenterologist for one opinion. Let's give a big hand to our panelists and of course to all our audience. That's all for today. We'll come back with one more session sometimes later. Thank you very much. Good day. Goodbye.